chronic medical conditions. As always, please be aware that this is being recorded for educational purposes. Your agreement to being recorded is inherently implied by staying on the call. For those that do not wish to be part of this recording, please leave now. This does qualify for Category 1 AMA CME credit of 1.5 hours and Virginia Nurses Association 1.5 hour CE credit. Accrediting bodies are listed below, as well as those hours as mentioned. This desirable physician attributes provide patient-centered care, employ evidence-based practice, and work in an interdisciplinary team. There are no commercial relationships or bias to disclose from the Sovah Health CME Committee, Dr. Moore, or myself. Which is always a good thing, right, Dr. Moore? Yep. Our program evaluations, Mary Kent will be sending an email either later tonight or tomorrow. Please check that email for that CME evaluation form. Please use your full name, no nicknames, when filling that out so that we can make sure that that credit is attributed to who it needs to be applied. And if you're sharing a login with another individual, please just let the CME office know so that that evaluation form and CME certificate can be sent. For Sovah Health medical residents, your CME participation is tracked by your program coordinator and your residency coordinator. Your CME certificate will be emailed to the email address you've provided when you registered for this event. Nurses and nurse practitioners, please submit an evaluation form to receive your CME certificate. Contacts are listed below: Dr. Moore, Mary Kent, and Van Holt with address. If there's any issues, please just let that CME office know. Questions are always encouraged. We have Mary Kent and myself to help monitor those chat functions. Please remain on mute if you are not speaking. And if you ask a question, please ask a question and then return to mute so that it can be answered without background noise or distraction. Upcoming online virtual CME programs, quite a busy office. There's the annual Nurse Practitioner Symposium, Birds, Bees, and Disease, Saturday, November 16th from 7:50 a.m. to 12:30 p.m. via Teams. Will be 4 nursing CE credits. We have perimenopause and menopause, prostate cancer update, an STD update with Dr. Burns, and benign prostatic hypertrophy by Dr. Gridley. Thursday, November 21st at 7 p.m. will be our culturally competent healthcare and appropriate ways to collect sensitive patient data with Pamela Bivens-Pippin. That will be moderated by our very own Leslie Sturdivant, applied for 1 CME or CE credit. On to this evening's program, Dr. Michael Moore, improving treatment adherence for asymptomatic chronic medical conditions tonight. Dr. Moore, I mean, really, I could say a lot of things. He's been a pillar of our medical community here in Danville for quite some time. He is a practicing or certified nephrologist, I will say, has been in nephrology, but has done so much more than that. He's a member of Wake Forest University School of Medicine, Hypertension and Vascular Disease Center. In addition, he's a clinical professor of medicine at the Virginia College of Osteopathic Medicine and the Liberty University School of Osteopathic Medicine. His undergraduate degree and medical degree were obtained from the University of North Carolina, and his internal medicine and nephrology training were completed at the Johns Hopkins Hospital. In 2004, no one would be surprised to know that Dr. Moore was chosen as the AHA National Physician of the Year, in part for development of 2 nonprofit cardiovascular health improvement organizations, including the Consortium for Southeastern Hypertension Control. Dr. Moore is currently the Director of Continuing Medical Education for Sovah Health, where he was instrumental in developing the Sovah Health residency program. To be honest, the program would not exist without Dr. Moore's influence and assistance in doing so. So I can't thank you enough. I've worked with you now for 13 years, and I have enjoyed every bit of it. Time flies when you're having fun. Dr. Moore, it's all you.
Thank you so much, Dr. Gunn. And yeah, the time does fly. I would never have thought it had been 13 years. It seems like only yesterday when you were chief resident on internal medicine. But I do appreciate everyone being on the call tonight. And as I mentioned earlier when we were chatting before we began, Some of you have attended this talk. I hope it'll be a little bit different. I'm trying to make it that for everyone. But that being said, we want to talk about patient adherence this evening. And it's really pretty obvious that for symptomatic disorders like someone with a broken arm or symptomatic psoriasis or having symptomatic pneumonia, patients usually have no problem following recommendations. I don't know if I've ever seen a patient that didn't return to get the cast off of their broken arm. The problem that we face, though, is that probably 80% of what clinicians deal with in the medicine side of medicine are asymptomatic diseases, hypertension, type 2 diabetes, hyperlipidemia, certain anemias, and certain other conditions where the patient actually feels well when they come to see us. And they're there because some lab test or blood pressure has been noted to be abnormal, and we're there trying to convince them they have a disorder that is worth their time and money for the rest of their life to try to manage and control. And those are the ones in whom it's really become challenging to do so. A lot of the information I'm sharing with you tonight does come from the experience of the Consortium for Southeastern Hypertension Control. Very briefly, this organization, nicknamed COSEC, was founded about 30 years ago at Wake Forest, and it sought to help individual practices throughout the southeastern United States create better outcomes for their management originally of hypertension, but then lipids and diabetes, and it expanded to other disorders also. The core learning that COSEC achieved was known as the Goal Project, which was a 3-year practice-based learning experience for 69 practices across the Southeast in some 13 different states. The way the process worked was pretty straightforward. COSEC went in with a couple of chart reviewers and or a link to an EMR, the ones that had EMRs, and looked at their baseline blood pressure control rates, LDL levels, hemoglobin 1ACs, and they would determine for the practice how well they were controlling things. Then they would provide category 1 CME either in a live session or a webinar, come back in 3 months and see how things were going, were things improving. This cycle was repeated over a 3-year period 12 times, and it was dramatically successful. Several things came out of this. Almost none of the physicians at the time we did this major project had ever seen their outcome data. Now we commonly see it in EMR systems. And then secondly, we learned as we did the program what would make a difference and make things improve. Just as a quick snapshot, and I'm not going to, if you will, go into the weeds about that goal, but overall, there was a 53% control rate of systolic blood pressures among, in this particular snapshot, some 27 practices. We enrolled practices as the 3-year period went on. And on average, that the 53% was the worst control rate. The average was 73%, but we were able to, over the course of the program, improve blood pressure control rates as well as LDLs and hemoglobin 1ACs. This is a snapshot just of 2 of the centers known as cardiovascular centers of excellence. These were 2 North Carolina clinics where you can see the numbers. This study was reviewed externally by the CDC. They sent a team from the CDC to Wake Forest to review all the 3-year data, and they found it to be a highly significant and successful program. There's actual publications to support that. So from that experience at Goal, I'm going to be sharing with you a number of evidence-based medicine strategies that can help you help your patients get to goal when they have, in the case of this evening, hypertension, hyperlipidemia specifically, but really any asymptomatic condition these things apply to. One of the best ways to do that is to talk about a patient. So here's an example, a 68-year-old fellow who's a retired gentleman who's been a machinist for about 15 years, and he's been told he had high blood pressure as well as elevated lipids, LDL. He's married, basically has 3 grown children. His mother is still alive at 88 years of age, and the father died of a stroke at 64 years. He has 2 siblings who are said to be in good health. His wife is 65 years old. He's 68, said to be in good health. He doesn't use any alcohol. He does like chewing tobacco and consumes a package or pouch of beech nut chewing tobacco about every 3 days, or in other words, about 2 to 3 packs a week. He finished high school and went and learned a trade as a machinist. They have very limited income. Really, Social Security is all they have. They did not have an IRA, etc. And so finances are very tight for them. Past medical history, he had lost his left distal index finger. That's typical of a lot of people that have had a career with a fast moving machine. He had an appendectomy in years gone by, but really has not had much preventive health care as far as immunizations or periodic colonoscopies, no allergies. And these are his medicines. And I just want to slow down a minute and I want you to think about these, because this gets really important about creating a program in which you can help patients stick with the prescriptions. So he's on thiazide once a day, hydralazine 50 milligrams 3 times a day, propranolol, a pan beta blocker, 60 milligrams. And they don't make a 60 milligram tablet, so he's taking a 40 and a 20 twice a day. Enalapril, an ACE inhibitor, 40 milligrams twice a day. Amlodipine, 5 milligrams twice a day. Baby aspirin, over-the-counter ibuprofen, 400 milligrams twice a day. He has a degenerative knee, as you'll see in a second. He's on a multivitamin he gets at the drugstore, and he's been put on simvastatin, 20 milligrams twice a day for his elevated lipids. This man's getting 17 prescription pills to take every day, and that amounts to 7 different prescriptions that he has to pay a copay for in many cases. When a 13 dimension, which is what we teach the residents to do, a 13-dimensional review of systems was done, he reported that he sleeps poorly, often has scary dreams. He also has roaring in his ears, tinnitus from his machine work over the years. As you can see, he wears glasses. He has some swelling in his ankles each evening. Now, remember, he's on amlodipine. That's not an uncommon side effect from a drug like that. Musculoskeletal, he has a left knee pain, said to be degenerative arthritis. He uses a cane, takes the ibuprofen when he needs to. These are his recent labs. They've been done periodically. He's followed in the clinic, as you're going to see in a few minutes. And his labs, as far as any end organ disease, are really pretty good. His renal function's normal. Creatinine's 1, potassium's normal. A random sugar, 177, probably okay. Serum calcium normal, 9.6. His TSH, thyroid stimulating hormones, low, which is what you want it to be. He's not hypothyroid. His urinalysis at 1 plus albumin, which is what you can see when you have uncontrolled high blood pressure. You'll see his is. And an EKG had some left ventricular hypertrophy. Again, an indication his blood pressure has not been at goal as much as you'd like it to be. And his last LDL cholesterol was 90. The goal was to get him less than 70. You recall he started at 120, so that's kind of part of the way there. He's been followed 5 years in your clinic, and you're one of 4 providers in that clinic. And each of the 4 providers, from time to time over the 5 years, has seen the gentleman. He's not tracked with just one doctor, nurse practitioner, or PA. His blood pressure, when first seen in the clinic, was 160 over 105, that's stage 2, and his LDL was initially 120. And as you'll see in a moment, he's had trouble getting to goal for both. At each clinic visit, to the clinic's credit, he's been given a written list of his medications and any changes that the provider has indicated he should be making. So the question comes up of which disorder does he have? Does he simply have resistant, very severe hypertension, hyperlipidemia, the worst case you've ever seen? Or is he just not taking the pills as prescribed? And the question is, and the fundamental focus of the talk tonight, is how do you sort that out? This is not an uncommon problem at all. Now, to have resistant hypertension, the American Heart Association, the American College of Cardiology, and all the other professional organizations that deal with high blood pressure agree that when you want to say it's resistant, it means that the patient's taking at least 3 classes of antihypertensives. That's like an ACE or ARB, a CCB, a beta blocker, and that one of those is a diuretic. Well, bless his heart, as you can see on the right, he's on, as you can see listed there, 5 different antihypertensive drugs. So he technically meets the American Heart definition of resistant hypertension. But the question is that really what the problem is? Here is a summary of his last about 6-month clinic experience. So it's a reverse chart. I don't know if you can see my point, and I don't think you can on the screen, but it starts 6 months ago at the top. And at that time, I mean, he's been in the clinic 5 years. This is 6 months back. His pressure was 160 over 100. He at that time was on thiazide once a day, and simvastatin was started at that time once a day for his LDL being elevated. He was seen back a month later. The blood pressure is 160 over 98. What's that 98 mean? That means you wish it wasn't 100. The cuff can't measure a 2 millimeter change. It's plus or minus 7 millimeters standard error with a standard blood pressure cuff with good technique. So basically, there's no change in his blood pressure. So to the clinic's credit, they added hydralazine, 50 milligrams, 3 times a day to the thiazides. He's back a month after that. Blood pressure is 170 over 95. The doc is a little cheered because the diastolic appears to be a bit lower, but he's not at goal. So the beta blocker, propranolol, 40 milligrams, that's a 1 tablet twice a day, prescription's added. He's on 3 drugs. A month after that, the blood pressure is really unchanged 3 months ago. So the propranolol is increased. You tell him break the tablet in half, take 1.5 a day. 2.5 months ago, they brought him back in 2 weeks. Basically, the blood pressure really was a little better. Again, the doc's encouraged 150 over 95. He's not at goal. So they add to all that an ACE inhibitor, 20 milligrams a day, beginning dose. Again, 2 weeks after that, he's back again. The blood pressure is not changed. They increase his enalapril to 1.5 a day, and they double the simvastatin. He's taking 1 in the morning, 1 in the evening. The LDL's down a little bit from 120 to 97. That's sort of encouraging. And then a month and a half ago, he's back 170 over 95. The ACE is increased again. They asked him to take it twice a day along with all the others. And then a month ago, he switched to enalapril 40. That's a new prescription. And then finally, 2 weeks ago, before your clinic visit, he has amlodipine added to the regimen, a 5 milligram tablet twice a day. And then you have your clinic visit. So the blood pressure in the clinic that you validate yourself and you're very confident is 160 over 100. He's afebrile, the weight's unchanged essentially. You examine him carefully and you look at his fundi and you see that he has maybe nicking, that's arteriovenous crossing scarring that you can see, which indicates he's not had well-controlled hypertension. There's no papilledema, no hemorrhages. There are no bruits over the carotid. You flex his knees and you feel the little joint mice and it feels a little dystrophic. And he really can't totally flex it backwards. He couldn't ride a bike if you ask him to do that. Of significance is he doesn't have any abdominal bruits, renal vascular disease, no S3 gallop for heart failure, and there's no edema in the clinic. Now, the point I would make here is, and this is a major pearl, this is take-home stuff. If when you're seeing him now 6 months into this saga, his blood pressure is 160 over 100, and that's where you started, I will tell you, and he's allegedly taking 17 pills a day or so. By and large, that's someone not taking the pills. Blood pressure pills lower your blood pressure. There's no question about it. If you've had the experience of taking even 25 milligrams of thiazide or 20 milligrams of furosemide, you'll know immediately that you got to go pass a lot of urine. So these drugs do things. So an unchanged blood pressure with multiple drugs is, in other words, a good predictor that adherence is an issue. Well, before you can say he's not adherent, you really should think about these 5 things that can get in the way of patients who are taking their medicines from actually getting to the goal you and the patient are trying to reach. One is something called physician inertia. This was first described by a family doc in South Carolina who made the observation about looking at clinic records that in many cases, when a patient came to clinic and they were not at blood pressure goal, they were hypertensive, not at goal, the doc didn't do anything. It was the old famous comment, well, let's see how you do, work on the diet. I know you can lose some more weight. Maybe you can walk some more. Known in the business as physician and nourisher, but that's not his problem. At every visit for the past 6 months, he's had a drug increased. The other thing to think about is he's taking the pills, but are other medications getting in the way? So for hypertension, the most common is nonsteroidal anti-inflammatory agents. Everyone on the market causes basically fluid retention. They prevent the dilatation of the afferent arteriole. They slow flow through your nephron, and they create a situation that makes patients retain fluid, which tends to blunt the antihypertensive effect of the blood pressure pills. The other things that can do that are amitriptyline, steroids, making you retain salt to the distal tubule. Phenylpropylamine, that's what's in cold remedies. And by the way, it was announced today the FDA is removing phenylephrine from all over-the-counter cold remedies. That's anything that has a D with it, like an antihistamine and phenylephrine combination. I don't know what's going to happen with the nasal sprays. That wasn't part of the description, but that can raise blood pressures. And then chewing tobacco. The tobacco doesn't raise your blood pressure, but the licorice that holds the tobacco together in the chewing tobacco has something called glyceric acid in it, which is a mineralocorticoid-like substance, i.e., it's like you're actually chewing or taking in, ingesting aldosterone. And so chewing tobacco makes you retain sodium and dump potassium. And that happens when you're using as much as 2 pouches a week. There's New England Journal studies confirming that. For lipids, things that make lipid therapy not as effective include thiazides and beta blockers. They basically raise cholesterol and to a greater extent triglycerides. As I'm sure you may know, steroids and androgens will raise lipids when they're used for other purposes, and then cyclosporin and HIV protease inhibitors. So our patient is on or is using 4 things that could get in the way of the drugs that he's taking for his blood pressure and for his lipid elevation. As an aside, this is a snapshot of another patient. This isn't our friend we have sitting in clinic. This is a real example of a 75-year-old lady with normal renal function who had been on meloxicam. That's a non-steroidal drug. She had been taking it for several weeks. So the beginning dose, 7.5 milligrams, 1 to 2 a day for her knees, degenerative arthritis. And as you can see at the top, in November, early November, in this picture, she basically was running stage 1 hypertension, 140/90, 134/96. She stopped the drug, the meloxicam. Nothing else was changed. And within a week, her pressures were back to flat normal, 100/70. So nonsteroidals really can affect blood pressure. And again, in our patient, he's been taking a significant amount of ibuprofen. The third thing to think about is whether he's making any lifestyle changes. So again, pearl to take home is if a patient will truly do lifestyle changes for blood pressure or cholesterol management, it's equivalent usually to them being on one antihypertensive drug and or at least partial drug effectiveness of a statin. So which lifestyles will make a difference? Well, this is from the most recent set of high blood pressure guidelines that we have to work under, and those were done in 2017, published in 2018. And what's summarized there, and this was done by Dr. Paul Welton at LSU in New Orleans, basically this is what each of these will do to help lower your pressure: weight loss, the DASH eating plan, lowering sodium, taking potassium supplements, alcohol reduction. As you can see, the one that has the most bang for your buck is the DASH eating plan. That's a dietary approach to stop hypertension eating plan. It was developed by Dr. Martha Hill, who was the dean of the School of Nursing. Martha, prior to doing that, was my first nurse practitioner when I was a fellow at Hopkins, where she was instrumental in actually developing the Hopkins nurse practitioner program. But she and a fellow named Dr. Larry Appel, who was a cardiologist, developed this diet and tested it with real people in East Baltimore, basically buying their food for 6 months, completely helping them cook the food properly, and showing that if you followed a DASH eating plan, which was basically fruits and vegetables, low-fat dairy, rich in potassium and calcium, you got about a 10 millimeter systolic reduction and about 5 to 7 diastolic. She also showed that if you added low salt to that effort, it would lower it even further. Parallel to that, the DASH diet also lowers cholesterol. And I've given you a reference here, and we're going to send you these references out after the program. There's similar studies showing that a low fat diet can drop total cholesterol about 14%. So again, our patients not had any efforts made about lifestyle changes. The fourth thing to think about is he on the most optimal type of drugs that have been shown, if used properly and in the proper or evidence-based combinations, can be expected to lower his blood pressure? Well, you might say, well, gee, they all have FDA approval to lower blood pressure. Well, that's true, but some combinations work better than other combinations. Some of the residents have seen this example I want to share with you. It's known as the four-legged stool model of blood pressure control. And I will tell you personally, from many years' experience, that there is no degree of hypertension that can really stand up to or not be controlled by utilizing a four-legged stool approach in general. There are some few exceptions, but there are not very many. And that's what you have to think about when you choose drugs for blood pressure management. If you think about this, there's only four fundamental major abnormalities that lead to high blood pressure. You can either have expanded plasma volume, too much salt and water. That's what happens in chronic kidney failure. You simply cannot excrete the salt and water you take in. Number two, you can have an overactive renin-angiotensin system. We're learning that there are inherent excessive levels of Ang2 and even aldosterone in certain walls of arteries, patients with essential hypertension. Thirdly, you can have an overactive sympathetic nervous system. So there's just too much tone in those sympathetic nerves, too much alpha restricting. And fourthly, you can develop resistance within the actual area with scarring in our walls. So it turns out we have a class of drugs that will address each of these problems. So you can, for instance, give an ACE inhibitor or an ARB, and you can really tone down, if not eliminate, the effects of angiotensin 2, or using a mineralocorticoid blocking agent like eplerenone and others that takes out aldosterone. You also can use diuretics, thiazide or furosemide to reduce volume, blood volume, salt and water. And you can use a CCB such as amlodipine, verapamil, diltiazem to lower peripheral resistance directly. And finally, you can tone down the sympathetic nervous system by either a beta blocker or beta blocker alpha combination like labetalol, or one of the sympatholytics. Those of you that are of my age that may be on the call, those are like our old friends alpha methyldopa and drugs like reserpine. So sequentially, if you want to get patients to blood pressure control, you would start with a DASH diet, weight loss if needed, reducing alcohol, etc. And then the first drug that works best is an ACE or an ARB. ARBs have the highest refill rate of any other drug, so the patient's more likely to stay on it, less side effects. To that, one can add a diuretic or CCB. It's additive. Numerous evidence-based studies showing that a diuretic or CCB, when combined with an ACE or an ARB, have added benefits. And then whichever one you didn't add then, you add the other one as the third step. So you can end up with an ARB or ACE, with a CCB or diuretic, or a CCB or a diuretic. And there are combinations that will give the patient all three drugs in one pill, which is really handy. And then the last class you usually choose are those sympathetic inhibitors, the betas or the betalols, if you will, drugs like alpha methyldopa, simply because they have more side effects and it's harder to stay on the drugs. But if one walks up that sequence, you will get blood pressures down. I will guarantee it. So is our patient on any of these, if you will, best choice drugs? Well, here's his drugs listed as I showed you on a previous slide. Out of that same list at the bottom now are his 5 antihypertensives. Thiazide, followed by hydralazine, a direct vasodilator. The problem with hydralazine is you get tachyphylaxis to it, meaning after you're on the drug for several weeks, the blood pressure doesn't respond as well because patients tend to retain fluid and it blunts the blood pressure's effect. He's also on a beta blocker and then an ACE inhibitor, and he's on a dihydro-CCB. Now, and I'll be more than happy if you want the references. There are within this list of 5, 3 excellent studied combinations that will lower blood pressure. So the combination of thiazide, hydralazine, and propranolol will dramatically lower blood pressures in stage 1 and 2 hypertension. This is the work of Jerry Porsche out of the Einstein Hospital in New York City. The combination of any ACE inhibitor with a dihydro-CCB, very effective, great evidence-based medicine. And then combining a diuretic with an ACE or an ARB likewise will lower the pressure dramatically. So he's on 3 great combinations of drugs. The choice of the drugs are very good, whoever his provider was. And then if you think about the lipids, we now know that lipids have different intensities, different statins have different intensities. He's on the lowest intensity, meaning the least bang for your buck from taking the statin with simvastatin, and he can switch up to, say, atorvastatin, which is much more effective, has much more lowering effect. And then again, you're using 2 different pharmacological mechanisms when you approach lipids. One is you block in liver HMG-CoA reductase with a statin. And then secondly, you can add ezetimibe, which reduces small intestine absorption of cholesterol. In addition, we now have some weekly drugs or even longer dose periods that can be given to actually work the other mechanisms or these same ones. So again, he currently is on if you will, a relatively weak or low intensity statin as far as one of the reasons he might not be getting to goal other than non-adherence. And then finally, the last thing to think about, does he have a condition in addition to hypertension that's not recognized yet that's interfering with his blood pressure and lipid efficacy? So you have to think about some of the secondary causes of high blood pressure that patients may have and which hadn't been recognized that actually makes blood pressure harder to control. Number 1 for hypertension is sleep apnea, obstructive sleep apnea. And after that is renovascular pheochromocytoma, Cushing's or hyperaldosteronism. For difficulty and secondary causes of hyperlipidemia, uncontrolled diabetes mellitus, usually type 2 in adults, polycystic ovaries in women, hypothyroidism, the nephrotic syndrome with swelling, low albumin, high urinary protein, pregnancy, and then the metabolic syndrome. You have to screen patients for these things when you initially see them for hypertension or for type 2 diabetes. For hypertension, 90% of the elevated blood pressure in patients is something known as essential hypertension. Runs in families, it's inherited. What do they inherit? An inability in 40% of the cases to efficiently excrete sodium. They take a salt load in, their pressure goes up. A normotensive person takes a salt load in, their blood pressure doesn't go up. And there's a whole variety of abnormalities in the sympathetic nervous system and the vascular angiotensin II system that underlie what's called primary essential hypertension. But in general, that diagnosis is made if they have a positive family history for high blood pressure or complications, and they have nothing else on physical exam except maybe evidence of uncontrolled hypertension, and they have normal labs. 10% of new hypertensives have one of these secondary causes that can make blood pressure harder to control. And you can see these, I won't read all these to you. It's either of the sleep apnea, which is the most common, followed by some problem in the kidney, one of these endocrine abnormalities, a drug, as we mentioned, that's competing or blocking the effect of the blood pressure pills, and then rarely coarctation of the aorta, very rare. One of the things that you need to be doing, and I imagine most of you are doing this already, is you need to be screening patients for metabolic syndrome, which is elevated blood pressure, excessive body weight. Those patients basically will have elevated blood sugars, they'll have higher LDL cholesterols and triglycerides. And what's been shown is you can screen for this two ways. One you may, I'm sure, know about is waist size. So waist size, if for a guy, if he's more than 40 inches in the waist, or a lady 35 inches in the waist, it predicts metabolic syndrome, and that's measured at the umbilicus. You will see these guys who, by goodness, will still be wearing a 34 pant when they've got a 48 waist and it's hanging over the pant. Well, you've got to measure at the umbilicus. And the other one, which is really, I always thought nifty when I learned about this a couple of years ago, was men's neck size and the neck size of women. This is how the Army, as you can see in the snapshot screens, their, if you will, new enlistees for metabolic syndrome. If the neck size is 17 or greater, if the man's wearing an 18 size shirt, he's probably got metabolic syndrome. And for a lady, it's over 16 inches. For sleep apnea, these measurements predict also the presence of obstructive sleep apnea. Beyond that, the so-called stop-bang screening tool for obstructive sleep apnea is the one that most sleep specialists, including our own Dr. Bird, recommend to you that's used. I know the same for Dr. Walsh in Martinsville. And again, these are asking these questions, which I'm sure you've seen before. If the patient has positive responses for two or more of these, you should be concerned they have sleep apnea and they would need a appropriate sleep study. To recognize patients with any of the endocrine problems, hyperaldo, Cushing syndrome, acromegaly. Acromegaly is really a pituitary-driven hyperaldosteronism. They all will present with a low serum potassium before they are begun on diuretic therapy. So if a hypertensive has a K less than 3.5, it's very important to exclude the fact of them having one of these three conditions. And you can do that very easily by getting a spot urine. If the K is low, ask them to pee in a cup. If the K in the urine is greater than 30 milliequivalents in that urine spot, basically they probably have one of these three abnormalities, these endocrine causes. If it's less than 30, it's usually from a GI loss of the potassium. But again, these are the type of things you need to think about when patients are not responding to your blood pressure meds or even your lipid meds. So to screen for these, basically it's recommended by the current guidelines. All new hypertensives have a basic metabolic profile, if you will, a 7-channel as we know it, with a calcium, a urinalysis, including a spun microscopic exam, a TSH for hypothyroidism, a CBC for general health, and an EKG as a baseline. And our patient had all these, and he's really in pretty good shape. His creatinine's normal, his potassium's normal on a diuretic. If he's taking it, his random glucose is not scary high. It would have to be fasting to screening for diabetes. His calcium's normal, TSH is normal. 1+ albumin could be the uncontrolled blood pressure. In fact, he had just some LVH on EKG. So you've gone through these things and thinking about our 68-year-old machinist, and aside from the fact that basically he's on some things that could be interfering with his blood pressure control medicines, and he's not on a DASH diet, and maybe he has a sleep disorder. He talks about the scary dreams and so forth, not sleeping well. You decide, well, maybe he is non-inherent. You thought he was non-inherent when he started. And therefore, how do you check and determine if the patient's not taking the medicines, given the fact you've gone through this differential and you've convinced yourself that I really suspect he or she's not taking the medicines I'm prescribing? Well, let me tell you what won't work. It's been well shown that trying to do pill counts are not reliable, meaning bring their bottle in and you prescribe 30 thiazides and you can see the date it was refilled and the date it is today, and you count the pills. That's just not a reliable way to do it. People miss a pill, skip a pill. The dog ate the pill, something happened. It's blood and urine drug levels are not commercially available to us in private or regular practice. Some drug studies will do these for different reasons. So you got to come up with something that works in the clinic. And what I'm going to share with you is what we did in that goal and what I've experienced and done for a number of years caring for patients myself. And so here's how to determine if someone's taking the medicines, as I'm outlining for you. Number one, patients must bring all their bottles to every clinic visit. That means not the list that someone made on a computer, but the actual bottles. And for those of you that may know, I practiced at the urologic clinic for a number of years. Our receptionist would stop them and they came in and ask them, did you bring your medicines with you? If they did not do that, the receptionist would say, please go home, get your pills, have someone bring them over. We're still going to see you today. It's not a problem, but we want to see your pill bottles. And you have to bring them to the clinic. Then you sit down, or you can train a nurse or an extender to do this. It's not magic. My experience has been the doctor or the provider does this. And the provider sits with the patient and takes the bag of pills and basically shows the patient each bottle pill, opens it up, shows the pill to him, and asks the patient, what's the name of the pill? The patient may or may not know the name, but we ask, how do you take it? And we're trying to get confirmation they know their medicine and they can tell you how they are trying to take it. If they don't, you reinforce what you told them to take. If it were thiazide, so this is your hydrochlorothiazide, it's a fluid pill, you're taking it once a day. The next question is, as the pill's in your hand and they're sitting looking at you and you're having a conversation, you ask them, when did you last take this pill? Now, if it was a thiazide, they should say, I took it this morning. Or a lot of patients will say, I didn't take it this morning because I was coming to clinic and I didn't want to have to go to the bathroom all day. And that's okay. That's cricket. We'll accept that. That's great. But ask them when they last took the medication. Then, if they tell you that they did not take the medicine or have not taken the medicine, they'll tell you. Then you have to ask the most important question of all. Why? Why did you not or are you not taking the medication? And I will tell you from experience, years of experience, they will always tell you. You have to listen. And when that happens, in my experience, the drug is dead, so to speak. We have a funeral for the drug. We say, well, gee, I'm sorry you had the problem, whatever it is. Let's just not use that again. You've got to regroup. But this will work. And it takes time. It takes face time. It takes time to chat with your patients and go through the list. Now, you may decide after 2 or 3 visits like this where they bring all the bottles that you're confident they're taking their medicines. You may want to backpedal and not put them through bringing the bag over every day. But the other nice thing that happens is when they bring all the pills, you see what else they're taking. We've had the problem in the past of where they say bring the pills. Well, they just bring Dr. Moore's pills or one of the other nephrologist pills and not all the pills. So we want them all the pills, shopping bag, whatever you're getting from the other physicians that you may be seeing or you've chosen to take over the counter. We want to see everything. The next thing after you do that, where you can actually convince yourself are they taking the pill or not, is you have to be sensitive to certain barriers that patients bring to each of us, and we have to be sensitive to this. And these are pretty obvious, and this isn't anything rocket science here. But first of all, visual. Now, our patient wears glasses, and so can they see well enough to identify the medicines and to read these instructions you're handing out? Number 2 is, can they hear? He has chronic tinnitus. I have tinnitus. I've had it for years from inner ear problems I had about 20 years ago. And basically, a lot of patients need hearing aids and they don't have the hearing aids. So can they actually hear? A lot of patients will sit, as you know, in a clinic and nod at you as though they're with you, but they truly are not hearing everything you say. The third thing, and our patient has this, is limited income. And that includes getting to the clinic. And we'll talk a little bit more about that in a few minutes, but limited income translates to being able to afford the pills. A good rule of thumb is you should never prescribe a medicine you do not know what it's going to cost that patient. You say, gosh, how do I know what that is? Well, you know the insurance, you have a conversation with the patient about what they're paying, and you basically, we would ask the question, so I want to add this new drug to you, amlodipine. Are you able to get this drug today? Can you get this prescription? And have a conversation about that and decide. And you want to be as cost effective as you possibly can. And then fourthly, and this may sound tacky, you think, well, everybody can read, but can they read? It turns out that about 20% of the US population can't read. This has been a fixed number for a number of years, and it includes Virginia. There's some ways to ferret this out. One is, does your wife read to, assuming it's a guy, does your spouse read the newspaper to you every morning? That's a common phenomenon if they're still getting the newspaper, or help you with things like that. Most street signs are third year reading level, so they can still be able to drive. I've had patients who were in managerial positions who had very poor reading skills. And then even more important than that is something known as health literacy. And it's estimated that as many as 40% of English speaking patients, this is Medicare data, have health illiteracy, and as much as half of Spanish speaking in the US have health illiteracy. And these are things like how to get refills, how to contact the provider with follow-up questions, how to get lab results once the lab's drawn if it's not shared with you in the clinic visit. The residents have heard me tell the story of a gentleman who came to see me in follow-up, and he was out of his medicines, he was off his pills. And I said, what happened? He said, well, I just ran out and I didn't know how to get the refill. I figured I had to come back over and you write me a new prescription, Dr. Moore. I said, well, all you had to do was take it to the drugstore. They call us and they fill it for you. He said, you mean they would do that for me? I said, well, sure. But again, we hadn't taken the time to explain to him. You think, well, that's silly. It's not. A lot of patients, a lot of people don't know how to do this. And medical care is very complex now. And there's a lot of gaming that happens in the system. So for new patients, they actually need to have a session with someone in the clinic explaining to them, this is how the clinic works. These are the things you need to know. And we as providers need to be able to screen them quickly about the health literacy. And this is one of the things I think you can take home if you don't already know about this. This is a real nice study from the Journal of Family Medicine. This was done a number of years ago, but it works. You simply have a card with these 8 words typed on it or printed clearly on it, and you simply ask the patient to read them back to you. And if they're not able to read those back to you easily, basically they probably have issues with health literacy and with reading. And then you can deal with it from that point on. So let's get back to our patient and see how we can improve his situation. So remember, he's 68 years old. His pressure is 160 over 100, not at goal, taking some 17 prescription drugs, and indeed also has hyperlipidemia, taking simvastatin twice a day. And that's listed for you on the left. So the first thing we would do would determine his literacy. Can he read these lists we've been giving to him? And if he can't, we make him a sun and moon chart. And that's simply a piece of paper or cardboard. You draw a sun at the top and a moon at the bottom, and you tape onto that cardboard one of the pills at each of those 2 different places. And therefore, they know how to take the pills. You think, God, I can't believe you would do this. Works if the patient really has trouble reading it. You also have him bring the med bottles in so you can review them with him. You'd ask him to try to stop the ibuprofen and suggest he use just acetaminophen and baby aspirin for the knee if he can get by with that. Basically, we'd ask him to take his simvastatin, the 2 pills at bedtime. It's more effective when taken at bedtime to affect the cholesterol levels. And then when that next refill comes up, you would move him to a more intense moderate to high intensity statin. We'd ask him to do the snore score test to get that out of the way. You don't have to be obese or excessive body weight to have obstructive sleep apnea. We would try to get him to reduce the chewing tobacco. That's a tough thing to do because people are totally addicted to the nicotine and the if you will the whole thing about chewing the tobacco. It's hard, but that would help a great deal and reduce his sodium retention. We would explain the DASH diet to him, the eating plan, give him a handout. You can go to NHLBI, you can print these off. They're real nice one-page handouts. Review it with the patient. We would taper and stop the hydralazine. He's probably tachyphylactic to it, as well as a herbal product, which you don't know what he's taking with that stuff. We reduce the propranolol to 40 milligrams twice a day, trying to maybe reduce some of the scary dreams that occurs with the lipophilic beta blockers, which propranolol is the most. We would ask him to say back to us whatever the final instructions that were given to him were to see if he really has heard it and understands. We would ask him to please bring someone with him to the next visit. If the spouse is out in the waiting room or the brother that drove him over or a child that brought him over, ask his permission to bring them in, make them part of the visit so they understand what you're asking him to do. This would allow him to be on these medicines going home. One Thiazide a day, one enalapril twice a day, one amlodipine twice a day. And if this was working in 2 weeks, you might be able to, the next time you write a prescription, get it into a combination drug. And finally, we would teach him home blood pressures and see if he can arrange or you can arrange for him to get a blood pressure measuring device at home. Now, that's a challenge. He has limited income. He doesn't have enough money probably to just go to Walmart and buy one of the blood pressure measurement devices. But if he can get one, that would be helpful. And we would see him back not in a month, but in 2 weeks. The 2-week message is this is important. We need to see you back. We need to get your blood pressure controlled. Now, given all that with a patient example, I want to end up the talk in the last minutes we have together to talk about what strategies you can use to try to set up your clinic experience to reduce the risk of poor adherence of the patients that you deal with. You know, when I started doing this a long time before many of you were ever born, it really bothered me. I didn't think I could stand up and tell physicians in a lecture CME program that poor adherence was their problem, not just the patient's problem, because many providers will immediately say, oh, that's a non-adherent patient. That's someone that stays up all night figuring out ways to make me, not do what I've asked him to do. I don't think that's the way it works. I think the adherence is the provider's responsibility. It's our challenge. It's our burden to create a world that patient can live in. And I've got to be able to do that so they can be. I think patients want to be helped. They made an appointment. They took half a day. It takes half a day to go see a doctor. It takes half a day for them to come and talk to you about something. They are motivated just by being there. They want to try to do something to help themselves. So we have to make it work. So here's some ways that you can help them make it work. Number one is you have to become a method actor in your approach to patients. The classic method actor, Marlon Brando. James Dean was another one. Paul Newman is another one. These are actors who learned their skills, their trade, as it were, back in the 50s and 60s. And the school of method acting, meaning the actor took on the entire personality of the person they were impersonating. So Brando, when he did The Godfather, never came out of character. When he walked off the set and they said, cut, film it, whatever, he would go to his trailer and he still was Don Corleone, no matter what. Other actors trained otherwise are not like that. Meryl Streep's not a method actress. She stops the scene and she's back to being Meryl Streep. But you want to be a method actor. What does that mean? That means you have to figure out everything about their life. Who's at home with them? Where do they work if they're still working, or what do they do in their retirement? Who prepares their food? Are they doing it, or is there a spouse? The spouse needs to know about the DASH diet. How do they get transportation to the clinic? The example I told you about the fellow who didn't know we would call a refill in was paying someone $10 to drive him to the clinic from North Danville in order to see us. So that was something you have to figure out and help them with. Also, are they using alcohol or drugs or smoking? And finally, what do they do in their spare time? You really have to understand what they do. Another example, patient who was having trouble controlling their pressures, she was a restocker at Walmart at night. She went to work at midnight till 7 a.m. She had children in school, came home, sent them to school, went to bed, then went back to work when they were all in bed again. She worked all night. And so telling her to take the pills in the morning got very confusing, as well as things during the day and what she took to eat for her break at 3 a.m. You have to understand and learn what patients are doing. Home blood pressure measurements are currently now the gold standard for how to diagnose and to treat high blood pressure. You treat the home pressures if they're done properly, not necessarily the clinic pressures. This is the best example of the value of home blood pressures. This is a study from the New England Journal of Medicine, 63,000 hypertensives over a 10-year follow-up. In Spain, you as a physician, if you want to, can enroll your patients in their National Health Service registry, where they'll simply track your patient and all the things over the course of the life. And they were able to create a situation where if they enrolled the patients got home blood pressures measured serially over the years they were enrolled in this, if you will, data set. And what was shown was that 27% of the people had white coat hypertension. They actually had higher pressures in clinic with these automated systems than they would have at home, and that 5% had masked hypertension. Masked hypertension means that basically they're normal in the clinic, but they're high at home. And here's the example of that. So this was a 10-year follow-up, and what's shown on the vertical, the risk of dying over the course of what their blood pressures were. So if you look at the bars, there's 4 colored bars. The green bars are clinic blood pressures taken manually in the traditional way with the best possible way to measure their pressures. And you can see the pressures were fairly good. But if you then looked at the chance of actually dying, of having death from a complication of their blood pressure, that's shown in that light beige area. And those are their out of office nighttime blood pressures. So the point is, those who had on the left out of office nighttime blood pressures at 120 had very low death rates, whereas those that had out of office high home night blood pressures had very high risk of death. So again, home blood pressure monitoring is important. They should bring the device into your clinic. You or one of your staff should validate they know how to take the blood pressure, use the device. They write down the numbers, not written, not done. They ask them to do usually once or twice a day, same time, once or twice a week, not every day. I've had some bad experiences of patients taking it 6 times a day. One patient actually had a roll of paper, 12-foot long, with all these blood pressures graphed. It was a disaster, and he was self-medicating. But once or twice a day, usually twice a day, once or twice a week, write down the numbers, bring them in. If the pressures are consistently high, contact the clinic. If they're doing well, you tell them the range that's well. You'll see them on the next follow-up. Bring your pressures with you. This is a great slide about effective communication. I talk to the residents a lot, and last time I talked to them about effective communication last academic year, I was sad to say that only one person in Hoover Auditorium had ever seen the movie Cool Hand Luke. Well, that is just sad. So if you've not seen Cool Hand Luke as a movie, you got to see it. Academy Award winner, 100% on Rotten Tomatoes, outstanding. Paul Newman is superb, and the best scene in the entire movie is Strother Martin, who's shown here with a white shirt, is the captain or warden of the prison farm where Luke is a prisoner, makes the comment after Luke tried to escape twice, talking to Luke saying, what we have here is a failure to communicate. Classic Hollywood moment. You got to watch the movie if you hadn't. The effective communication is something you have to do. As I was taught in med school at UNC, nothing beats talking to the patient. And you have to do that in the clinic, eyeball to eyeball. This doesn't mean with them perched on the end of an exam table. This means both of you sitting next to one another, having a real conversation. That brings up the whole issue about the laptop. So now we're all EMR dependent, and it is a skill set to know how to deal with the laptop and deal with the patient in the exam room. And some places, you'll have physicians who don't bring the laptop in the room, or there's a desk model they have there, they don't use it, and they do all that logging once they've had the visit. They come in, sit down, talk to the patient, examine the patient in their traditional clinic experience, and then they go log on the computer. Others try to work on the laptop, and sometimes the patient's left out of the conversation. You really need, when you do this, if you're going to use the laptop, let them sit beside you. Both of you look at the laptop. Remember, it's their data, not yours. And there's nothing wrong with both of them sharing that with you. You need to look at the patient and have eye contact. Besides that, you need to be able to speak the patient's language. Now, we're going to have a program in 2 weeks. Dr. Gunn mentioned this to you. Ms. Pam Bevins, who we've had several times, is going to talk to you about taking culturally competent information from patients. I used to laughingly tell, as I taught this, do you speak Southern? But it's broader than that. It's being sensitive to patients' customs, what their life's like, and there's ways to do this. And Pam's going to help us all learn how to do that better. But you have to be able to communicate within their, if you will, culturally sensitive way. You need to know the patient before you enter the room. Grabbing the chart and going in the room and looking at the patient, and it's obvious when you're looking at the chart to try to find out why this patient's in the room and what you're supposed to do, that is just tacky. You need to take a few minutes before you enter that room, know who they are, and know why they're there. And you have to ask them, hey, why are you here today? Set up the agenda. This helps so much. Most patients, this was shown at the University of Missouri years ago in family medicine clinics, patients on average have a 1-minute opening statement about what they want to talk about when they're in your clinic exam room. And 1 minute is a long time. It feels like an eternity. So you need to go in, sit down, eye to eye, everybody's dressed, and you say, so it's good to see you, Ms. Jones, Mr. Jones. Tell me why, well, what brings you in today? Is this fall for your blood pressure, whatever? And then stop talking. Let them tell you. What you want to avoid is the hand on the exit door knob crisis. And that is you've had a visit about the high blood pressure and you're getting ready to leave the room. And the patient says, oh, by the way, I think I've had blood in my urine. If that happens, your world stops because blood in the urine is huge. You got to get a urinalysis. You've got to have another whole set of questions. You may have to do a pelvic exam depending on the situation. So by getting that agenda out first, the patient feels better that they're being heard and you can decide what has to be done. I can't emphasize this so much. You need to have most of these conversations with everybody dressed. There's some clinics I've seen where patients are put up in a gown before the doctor even comes in or the provider, okay? That's very, very uncomfortable and not very promotive of actually a good conversation. Have the conversation, talk with your patient. Then if there's to be an exam, ask them to slip off the shirt, have the nurse help if it's needed, if it's appropriate, and never, never be judgmental. Always touch the patient. That sounds silly. No, you have, I mean, quite honestly, once you have examined the H&P on a patient and you know all then if you will, the initial workup, following up on blood pressure, it's just usually about the blood pressure if they're feeling well. But it's so important to have physical touch and to do that as part of your visit. You also have basically a plan on education. So you got to figure out the literacy thing. And if they can read and utilize information, then you want to be able to have lists for those folks. And you want to always use the SABAC program once you've gone through this before you exit the room or finish the visit. So tell me now, what are we planning to do when you come back, or do you understand what we want to do? Let them tell you back what they're going to be, what you're asking them to do. Now I want to tell you a story that I love to tell. Some of the residents have heard this before. This is a true story. A physician is a local physician. This physician had a great sports car. And unfortunately, she comes out of her home one morning and there's a big black oil spill under the front of the sports car. This is not good. Oil under your car is never good. But she's a smart lady. She actually is able to open the hood, measure the oil with the dipstick, determine that it's full, and calls the dealer and says, well, it's probably okay. Drive it on over, bring it over to the dealer. So she takes it in to her dealer. And when she gets to the dealer, there's a service manager. Nice guy, really good guy, real salesperson. And he tells her, oh, gee, Doc, you know, we had a car like yours in here just last week with an oil leak like yours. It cost over $700. It's hard to get to that part of your little red car that leaks. But you know, we're going to bring it in, we're going to put it up on the rack, and we'll have one of our technicians check it out. And once I know what the problem is, I'll give you a call and let you know what the damage might be. And so later that afternoon, and Dr. Jones is seeing patients, overhead page is, Doc, your car service is on line 3. Can you pick up? And she picks up the phone, and the car service manager says, great news, Doc. We can do it for $126. How do you think the doc feels? The doc's happy because the service manager exceeded the expectation he set when he told her it was going to be about $700. And she thinks that's great. Truth be known, what was wrong was when they changed the oil on the little red car 2 weeks ago in this service thing, they put the filter on crooked, and it's their fault. There wasn't even a leak. There shouldn't be any charge. But she's happy. Exceeding customer expectations has been shown in the business world, and this was mainly done at the enterprise car dealerships, causes several things to happen. You increase your return business if you exceed expectations. You create more returning customers, and it translates to more profits in the business. And guess what? This translates to healthcare. This work was published in JAMA, which shows that if you exceed a patient's expectations in healthcare, they're more satisfied. They increases their choice. They're going to choose to come back to you or to your organization for continuing healthcare, and it significantly reduces malpractice actions. If you tell them, for instance, your loved one's procedure is going to take an hour and a half and they're back in recovery in 40 minutes, that's great. You don't tell them a fib, you're very honest about this. But if you can exceed expectations, you do good. Now, the problem is most patients have no idea what to expect. So it behooves us as providers to set the expectation, and therefore there's a frame of reference as to whether we met them or we did not meet them. And if you can exceed them, you really come out great. So the challenge you have in lipid management, hypertension management, type 2 diabetes, glycemic management is that, or even surgical procedures, is that the provider's expectations, what you expect to do, and your patient's expectations are the same. And when that happens, things turn out really well and patients are more adherent. So a physician in blood pressure and lipid management should know, first of all, that you can get all patients to goal. You can. I have only had one patient in my whole time that I knew about for years that I could not get to goal. But I can get you to goal if you work with me and so forth. Number two, antihypertensive and lipid drugs and how they're prescribed, the provider needs to know that makes a difference in how well they work. That is effective combinations. The provider should know that patients should be able to get to goal in 3 to 5 follow-ups, and that's work from the value trial. The quicker you get patients to goal, the less complications they have. And that tells you it's not like 6 months or more we've seen in the patient we looked at. That's probably within 3 to 4 clinic visits at 2-week intervals. All hypertensive patients and many lipid patients are going to need more than one drug. Telling them that at the beginning is really helpful. The patient should expect and be taught that lipid and hypertension management is lifelong. The day you die, you should have taken your blood pressure pill. Hypertension, high lipids are asymptomatic. You're going to feel well unless there's an event, which we're trying to prevent. The meds for hypertension as well as for lipids, except for some of the injectable lipid drugs, last only one day. The provider, they need to know I can get you to goal. Just work with me. Also, that lipid management and high blood pressure management are great financial deals, meaning the cost of the medicine over 20 years is so much less than having a heart attack or a stroke and the inherent disability that occurs with those two type things. It's just the greatest deal in the world is buying one, two, or even three meds a day. Given the fact you can afford them, the economic investment value is tremendous. And you're going to need 3 to 5 visits. So seeing a new hypertensive, what typically I would do is I would tell them I want to see you back every 2 weeks, and I'm sure we can get you to go within 5 follow-up visits. If after 3 visits I've got them to go, they'll say, wow, he's good. He told me it would take 5 follow-up visits. If on the other hand, on that 5th visit, I'm adding the 4th drug and worrying with them still, they say, gosh, Dr. Moore told me this would be hard. So you set the goal, the expectation parameters, and then it works so much better because they know what to expect as you move forward in the treatment. And then finally, you will probably need more than one antihypertensive drug. Patients need to know right up front that for stage 1 high blood pressure, you need 2 drugs. You're not going to get to goal unless you have an animalistic lifestyle change with one drug usually. And if you have stage 2, which is again 40% of the patients, you're going to need as many as 3 or 4 drugs. This is a work of the late George Backwards at the University of Chicago, showing us how many classes of drugs are needed. So patients don't know that. They think one pill, well, Miss So-and-so, my friend, she takes one pill, her blood pressure is fine. Well, we don't know if her blood pressure is really fine or not. That's just sort of hearsay. But for real care, they're going to need more than one medicine. Finally, let's talk a little bit about how the clinic and the clinic's design and process can promote better adherence for your patients. Clinics need to be, and this is part of the Sovah mantra, a place where patients want to come for care. Patients have a choice. We are actually in a very competitive area for healthcare. We have Duke and Moses Cone and Centra and other great care facilities, as well as our own clinics at Sovah Health. So patients, it does make a difference about how they experience what they see in clinic. So clinics should be open at convenient times. There was back in the day, one of our local internists or two started doing 7 a.m. visits for people that had to go to work at 8. That was great. At the urologic clinic, we saw patients back in the day all through lunch hour because they could come over at lunch and we made sure we got them out if they were there on their lunch hour. Access physically to the clinic should be easy. A good example is Dr. Kaplan, Dr. Bavaja, Dr. Desai's office is over an Executive Drive. You can pull right up to that curb and you get out, and it's only about a 30-foot walk into the clinic where you can sit down. For older patients, that's a huge advantage. The clinic needs to look good. It needs to be well kept. Don't have any peeling wallpaper, nice carpets, etc. And you need to have friendly, knowledgeable staff. Everyone has a name badge on. A name badge gives you accountability. When there are no name badges, it's not at all user friendly. In addition, you need to have patient centric seating. Now, the airplane seats, I don't know if you've flown recently, but they're actually smaller than ever. And so a lot of times clinics will have, if you will, mass seating arrangements. And some of the things that can help patients be much more comfortable in a clinic setting, which makes them not feel so threatened by coming and having the follow-up visit, for instance, are taller chairs for older people who have degenerative knees and they can't really sit down in a lower chair. Also having chairs that are wider because unfortunately, a lot of our patients are heavy, and having a narrow chair is really, really difficult for those patients. Also, in an exam room, having the patient's chair seat, one arm is removable, like on an airplane. So if it's a wheelchair patient, you can transfer easily and simply make the visit better. The other thing is having some patient comforts. Many of our clinics on Sovah and there are others have, if you will, visitor Wi-Fi. Duke has this. Duke has free coffee Keurig machines in most of their clinics, which is a nice thing, as well as computer charging ports beside the chairs in a lot of Duke clinics. The other thing is when patients are called, that needs to be done with respect and a prefix. The person that stands at the door and just shouts out more, I mean, gosh, that is, it's so much nicer to say, Mr. Moore or Miss Jones or whatever. They need to be sensitive to that because patients feel better when they're treated with more respect. And then a huge thing is actively managing patient waiting times. That is turning out to be the critical factor, the most important factor, and what drives a lot of patients who abandon a clinic visit. And then finally, one needs to use the clinic staff to actually promote adherence. This is a reference. I won't go down to the details. This is a wonderful review article that basically in medical marketing talks about ways to make the clinic visit a very patient-friendly, user-friendly experience. We'll send you out this reference, 18 ways to improve the patient's experience when they come to see you. Finally, a no-show is the ultimate, if you will, non-adherence. They just didn't follow up to come and see you in the clinic. How can you try to reduce clinic no-shows? Well, two things that have been shown, evidence-based medicine, to improve show up are the automated appointment reminders. That's the phone calls that most clinics uses, or these little short messaging texting that's using. Another one is when the patient is initially seen, ask how they would like to be contacted, or if they don't want to be contacted. Both of those things make people like the clinic better. Also, you can implement a proactive scheduling process where patients are asked to check in online before the visit. That pretty much assures you they're going to be there. And then the major thing is trying to reduce the waiting time once they get into a clinic. 30% of patients who abandon their appointment, that means they came, they were sitting in the waiting room, they got tired of waiting, and they walked out, was due to long wait time. National average wait time now is 18 minutes or less. The goal is usually trying to get them roomed within 20 minutes. This is a huge problem. The other thing is once they're in a room, is actively managing what's happening in clinic time. Now, everybody has a situation where a patient may need to be admitted or referred over to the emergency room. And when that happens, the clinic flow stops. And you have to go in the patient's waiting to be seen by the doctor, tell them, well, we've been delayed. We're going to be delayed. We realistically 15, 30 minutes. Do you want to wait or do you want us to reschedule you? Giving the patient the option to reschedule or wait takes away all the anxiety that exists. Most patients will always say, oh, I'm fine. That's good to know. I'll bring them reading materials or something because it's going to be a little wait. But let people know what's happening. It's when they don't know is when they get frustrated. Transportation options are important by having bus lines that actually will stop, bring patients to your clinic area. And you're also rewarding people that show up, having a sensitivity in a patient database to thanking patients for coming, sending a note on birthdays and so forth. Many clinics do this. And then if you have a no-show policy, and you can charge for non-visits, you need to have that policy posted and let patients know about it so they understand that process. Then finally, you need to review no-shows every day. What that means is that you want to basically contact every no-show, and it usually with a conversation that says, sorry we missed you when you call them. You're talking to them, can I reschedule you? A lot of times it's a very real problem, meaning I didn't have a ride, or my kid got sick, or mama had to go so-and-so and I had to go with her. I'm sorry I didn't call, but calling each one is a real good thing to do, and it builds a relationship again with the clinic. And then finally, regularly and you can get this from almost every clinic now, having a monthly or a periodic EMR patient outcome report. In other words, like we did in COSEC, asking your system to tell us how well are we controlling blood pressures in guys, gals, whatever breakdown subgroups you want to do, and having a staff meeting and talking with your staff about that so they know what the situation is. At the end of each clinic visit, a staff member confirms what the provider instructed the patient to do. I had the great luxury for the many years at the urologic clinic that I had one nurse that quote, managed my patients all the time. Each of us in the clinic, each provider had a nurse. Some were LPNs, some were RNs. And basically, once I left the room, because we were using written notes on this, they would go in and go, well, what did Dr. Moore ask you to do? And they would reinforce the things that we asked the patient to do, changes and so forth. Always check for the need for refills on the visit, and always schedule the follow-up to see you. In the case of our machinist, he was there with 5 other people. If you're not going to be there in 3 weeks, 4 weeks, when you want them back, arrange it with someone and let them know who specifically they will see. Another tip that my dad taught me, dad built buildings for physicians, he wasn't a physician, is that one of his docs that he built the office for, he dad observed, he walked every patient back to the waiting room and thanked them for coming and spoke to their spouse. And the patients loved him. He had no no-shows. Really a nice touch, but you want to bring the patient always back to see you. And then always ask if there's questions. And finally, if you get a patient call or a note, a sticky note to call someone, emails or text every day, you respond to those things. And if you get a gift, send a thank you note. A handwritten thank you note is a really nice thing to do. That's how you build relationships. That's how you can very much have patients follow what the treatments are. So in summary, to ask you, don't forget this, I would highly recommend you consider becoming a method actor like Marlon Brando, so you can totally understand the patient's situation, if you will, that is, walk in their shoes for a while. Use home blood pressures or AccuChecks for type 2 diabetics, or weights if you're trying to lose weight. Daily weights work great. Try to design treatment that has the least number of pills that contain effective combinations of either antihypertensives or lipids or whatever. Make your clinic experience attractive to your patients, patient-centric. Try to create an effective communication. Use your clinic staff. I mean, they're there to help you. And while you're in one room, your nurse or your nursing assistant or others can certainly be talking to your patients to promote adherence. And then finally, set expectations so that you and the patient know where you're going on this journey, and they can judge how well you're getting there, and you will have a much better chance of having them stick with the pills long term. That being said, thank you for letting me talk with you and at you for the past almost hour and a half. If you've got questions, concerns, or complaints, I'm more than happy to answer them. I am going to ask Mary afterwards, that maybe tomorrow or Monday we'll send this out. These are some selected references that may be of help to you. And again, thank you so much for being on the call tonight.
You know, Dr. Moore, Dr. Saeed has located Cool Hand Luke on Tubi app for free. So for those that wanted to know, that is important. And I agree, good movie. Classic.
Excellent. Super duper duper. Yeah, sometime I can send out a list of best movies to watch from, but Cool Hand Luke is excellent, including him eating all the eggs. So any questions, anybody in it all, or you're among friends? Mary reinforced that we ought to be among friends tonight. Well, I'll tell you just one other aside. It's interesting as most of y'all know that have known me for a long time, I stopped doing regular clinics around 2007, 2008, when I moved into help with hospital leadership roles and things. And the thing, quite honestly, I miss most are the patients. because over the years, the 20-some years at the urologic clinic and years before that at Wake Forest, you build up friendships with patients, and the whole adherence thing becomes a non-issue. But it's interesting. I think everyone, unfortunately, now things are so busy and there's so many folks in clinic settings and all, but it is caring for patients, and the art of medicine is something that is a true privilege for all of us. And these ways, by building relationships, the adherence becomes not an issue, and legal issues just go away completely. It's just a privilege to take care of people. Okay, well, we won't belabor the time. If it's okay with Dr. Gunn, we'll say good evening. What do you think, Dr. Gunn?
Absolutely. I just want to thank you for taking the time and giving this lecture. I think we've had a good group, and I think it's really important information that was covered, and appreciate everyone attending tonight. More CMEs to come that were listed at the beginning, so keep an eye out. Happy to have you guys participate.
Take care. Good night. Bye-bye.